Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent education grant from Regeneron Pharmaceuticals, Inc. and Sanofi.
Hi and welcome. My name is Dr. Milan Han, and I'm Professor of Medicine and Chief of the Division of Pulmonary and Critical Care at the University of Michigan in Ann Arbor. Welcome to this program titled When Steroids Signal Risk Rethinking COPD Exacerbation Management. And joining me today is Dr. Nathan Falk. He's Professor of Family Medicine and Rural Health at the Florida State University College of Medicine in Winter Haven, Florida. Welcome, Nathan. Thank you for joining me today.
Thanks. It's great to be here with her.
All right. So we have a short amount of time, and so I'm going to just jump right into it with our first question. And that is why does steroid stewardship matter in COPD? Just curious for your thoughts on that.
Yeah, it's a great question. We know that steroids do play an important part in management of COPD, whether it's inhaled steroids or oral steroids in the management of exacerbations and things. But while we've gotten quite comfortable with their use over the years, we also know and need to recognize that they're perhaps not as benign as we thought they were. There's risks to multiple different organ systems throughout the body. We do know that cumulative risks, add up over time. So increased risks of, bone density issues, diabetes. Often these patients, especially our COPD patients, are a little bit older, so increased risk maybe of glaucoma and cataracts. And we now are starting to get multiple case reports where relatively shorter courses or steroid bursts have been shown to be risk factors for avascular necrosis. And obviously, the higher the dose, the longer we use steroid for, the higher that risk is going to be. But now we have multiple case reports in the literature of really one single steroid burst putting people at that increased risk. So we know also from the literature that even when it comes to steroid use around pneumonia or other hospitalizations, we want to have shorter courses, shorter durations, use as little as possible to get the job done. 10 versus 5-day courses. Those longer courses have actually been shown to increase risks of hospitalizations, increase all cause mortality. So we really don't want to use them more than we have to. So again, I think some of the things that we see on our end, incorrectly when it comes to this, or less optimal, shall we say, is starting too often with steroids for COPD. We've done some work where we've looked at first prescriptions by even particularly primary care physicians when presented with cases that are kind of classic COPD. And a large percentage of folks end up with ICS LABA as their first prescription. We know the starting place really should be that LAMA LABA, not jumping immediately to triple therapy, not jumping immediately to an ICS for most of our patients. And so really being mindful of those guidelines, not using those steroids, right away, unless there's a compelling indication to do so.
Yeah, I think it's hard because a lot of times we'll see those messages coming into our in basket. We want to deal with it, triage it, and move on. And steroids are sort of that initial go to. But I think over time, sometimes we forget sort of the implication that that has sort of over the broader course of a patient's lifetime. If they're getting that over and over, as you mentioned, it can have a lot of negative consequences. But I think it also um, can potentially signal that we're not treating the COPD or preventing those events maybe the way that we should. So, can you maybe for a minute help me think about that? So, like when we're writing that script, or that's kind of where we want to go, what should we also be thinking about?
Yeah, yeah. I think, we talk about the risks of steroids, and of course, we want to be cognizant of those risks. But I think, what you're, alluding to is that anytime that we are writing a script, so we're thinking we need more steroid, we need a, you know, burst of oral steroid, something like that. The question in our mind should always be why? Like, right? Is this a sign that they're not optimally controlled? And what else perhaps should we be doing? What else is, available for treatment? How do we need to change the treatment regimen? What do we need to be looking at from patient specific factors that would indicate that their disease is not optimally controlled? Because we ultimately we want to do those things to control it, because more exacerbations lead to more exacerbations and kind of spiral through. So that to me is also a really compelling reason to be looking at how much steroids someone is using, not just for the risk, but just the sign that there's probably something else going on that we need to do differently.
Yeah, I think the good news is we're increasingly coming out with better treatments and things that we can do to try to prevent disease. So when we see that call come in, we should not just be thinking, how do I treat this event? But we should also be thinking, is this a sign of something larger that maybe this patient isn't on maximal therapy? Gold, for instance, updated their document this year and now moved to essentially one exacerbation, signaling increased risk. Even one is essentially one too many. So I think as you said, now we all kind of need to be thinking about, okay, is this patient really maximally controlled or not? So I want to actually pose this back to the audience for a moment. And I want you, the audience, to consider this. How often do you reassess COPD control and future risk after repeated exacerbations? Okay, I want to continue this conversation. And I'm curious, Nate, what are some red flags for you that would signal uncontrolled or high risk? So we just chatted about the fact that, if they're calling in and having an event, okay, that's like maybe one signal. But what else are you kind of thinking about when you see that patient and follow up and you're kind of looking back over what's happened since the last time you saw them? What are for you some of the flags about this patient being high risk?
Yeah, yeah. I think obviously multiple exacerbations, right? So if someone has ongoing exacerbations despite you escalating therapy, so maybe you started with your lama laba, you added in a steroid to get to triple therapy. Now you've escalated that up to a high dose ICS, and you're still getting exacerbations. Recurrent oral steroid use, on the primary care side, they can get it from us, they can get it from an urgent care, they can get it from an ED. So having to be cognizant of all the places that they can get it from. Hopefully, they are no longer getting it from us in the little bottle in their medicine cabinet that they just keep right there. That's not optimal either. But the other thing that I always ask my patients and I always look at is the reason for exacerbation, right? Because sometimes you can explain, like they have an explainable exacerbation, if you will, right? So someone gets COVID, someone gets influenza, they get a significant respiratory infection or something like that. But sometimes we get these exacerbations in our patients with COPD seemingly for really not great reasons. They're just they're living life and maybe have a minor exposure. They go to the some place where they're around some low level of smoke, or they have an environmental change and it kicks off an exacerbation. And so if I start to see more and more of those exacerbations, particularly with kind of minimal exposure or not good reasons, I start to think, why is their disease progressing more? Why are we getting more exacerbations for no good reason? And what do we need to do then to help get better control from that standpoint?
So I'm curious, what do you think we need to do, kind of in practice? How can we better identify patients who are at risk for corticosteroid overuse early? What are some of the things that you're thinking about when you're seeing those patients in clinic?
Yeah, that's a great question. I think one of the things that really that we need to do right off the bat is make sure we get the correct diagnosis. And I know later on we'll probably talk about some of the testing and things, but the hardest COPD patient to treat is the one that we're trying to treat for COPD that doesn't actually have COPD, right? We also know there are multiple comorbid conditions, both pulmonary and non-pulmonary comorbid conditions that can be concomitant with COPD. Bronchiectasis being an example of a pulmonary one, where especially initially it might respond really well to some oral steroids, but then the more exacerbations you have, the more steroids you give, the more problematic that can be. So sorting through that is really important. Looking at conditions like GERD that can cause chronic cough, postnasal drip, allergic rhinitis, those kind of things, and really sussing that out, especially on the primary care side of things, in addition to other cardiac comorbid conditions. And then I think also really important is making sure that our patients are using their inhalers and their devices correctly, making sure that their BID medication is actually being used twice a day, not once a day. Making sure that they know how to use whatever device you've prescribed to them, right? We have these discs and puffers and ovoid shaped things. And unfortunately, sometimes we as the physicians think we're just going to write the prescription and then someone else, like the pharmacist, is going to teach them how to actually use the device. And that often doesn't happen, right? There's plenty of YouTube videos out there. There's a lot of resources that we can help, but whether that's videos, nurse visits, demo inhalers, we need to actually do that. And then, there's a really good poster from the Allergy Network of all the different inhalers out there. So that if your patient comes in, they've been prescribed one from someone else and they don't know how to use it, you can, put up the poster, say which one is it. They can point it out. We've got these posters all around our clinic. I mean, then asking about their triggers, I think, is really important, right? As we talked about previously, kind of those minor illnesses and things. To me, that's a little bit of a red flag. If someone has sort of a minor illness or a minor exposure kicking off an exacerbation, but are there avoidable triggers, right? Smoke being, a fairly obvious example, right? You need to avoid that if you know that that's one of your significant triggers. Helping the patients with some of those self-management techniques, and making sure that they know what to avoid, what around, what's going to kind of kick things off for them. So, with this escalation in mind, Dr. Hahn, when do you want to see them? When do you think primary care should be sending over these folks to you for evaluation and consideration of more advanced treatments?
Yeah, I think that's a great question. For those who are in primary care that are out there listening to them, I think the bottom line is we want to see them earlier. And so, so persistent exacerbations, I think, despite maximal inhaled therapy, 100%, we want to see those patients. Patients who, just maybe just don't seem like they're, fit the exact mold. And maybe there's some question about, differential diagnosis. The interesting thing is that not only do we have pharmacologic therapies, but there are also, now advanced treatments for some patients, including bronchoscopic and surgical interventions in some cases. So from the pulmonary side, I we want these patients. We want to be seeing them, and if there's something more that we can offer, um, you know. Then so be it. But we really would love the chance to look things over and see if there's something else that we can offer a lot of these patients.
Yeah, yeah. I think, from a primary care standpoint, especially, we talked a little bit about comorbidities and things too. When patients have comorbidities, eczema, maybe history of asthma, nasal polyps, all those things. Like we need to raise our level of suspicion that something else might be going on. And start doing some of this workup as well. And I've talked to several pulmonologists about how much do you want the PCP to be working up? Do you want them to be doing PFT spirometry, CBCs with diff, that kind of stuff before they come to you? What do you want to do? So from your standpoint, what of the workup do you want primary care to do before they come see you?
Yeah, that's a really good question. I think a CBC with diff is really helpful because, as you know, that can help us guide and guide steroid use. It guides biologic use, but honestly, beyond that, nothing. We like to do the pulmonary function testing a lot of times because we'll, maybe get a full pulmonary function test with bronchodilator that perhaps it wouldn't be practical for you to do, or is in we can do it like right when we see those patients, so it's really not a big deal for us to get it. And advanced imaging, if we decide that that's needed, I definitely want to be ordering that because we've got specific protocols to see if patients are eligible for those advanced treatments. So honestly, it's really not much. I would, I'm happy to do honestly most of it. I will just put in a plug that in terms of blood work, things that I will do in addition to pulmonary function testing and CT scan and the CBC with DIF, but I will also think about alpha 1. And, most of our, if you look at the guidelines, really all of our CPD patients should be screened for alpha 1 antitrypsin deficiency. I'm happy to do it. I'm also happy for primary care to do it. Either way is fine, but that's something else that needs to get done.
Yeah, absolutely. And I do want to second what you were saying about the doing spirometry in the office and things. If people, this is my plug to primary care, that if you're going to do it, I am a firm believer that you need to do it with the post bronchodilator. And if you're going to do it the correct way. So do a pre and a post, and make sure that you're doing the full thing if you're going to do it. So once they're referred, what kind of steroid strategies do you start to consider? And is there a pecking order, or how do you choose which one of those options that you were talking about previously for patients?
Yeah, so I think the first thing to do is to kind of optimize inhaled therapies. So, as you know, we've got long-acting muscarinic antagonists, long-acting beta agonists, and inhaled steroids. And for most patients, particularly if they have eosinophils of 100 or more at baseline, that's going to be kind of your strategy to reducing exacerbations and reducing the frequency of steroid use. Um, Beyond that, we've got a couple of different options. So if you kind of pull up the sort of gold document, you'll see the treatment flow really is dyspnea versus exacerbations. And on the exacerbation pathway, if you have a patient with eosinophils under 100, you're going to move up to dual bronchodilator, so lama lava. If they're 100 or more, you're going to go through the algorithm and you're going to end up on triple inhaled therapy. I think, at that point, we also probably want to get some additional workup just to make sure nothing else is going on. Sometimes I'll get a CT scan to make sure I don't have significant bronchiectasis, where I might treat that a little bit uh, differently. But then, if the patient is still really having frequent exacerbations, according to Gold, you've got a couple of options. So if the eosinophils are above 300, so 300 or more, we actually do have two approved options for treating patients with a biologic that includes either dupilumab or mepolizumab, both of which target type 2 inflammation and have both been shown in clinical trials to reduce exacerbation frequency. Dupilumab also demonstrated improvements in lung function and symptoms. And we have a lot of clinical trial data, both inside CPD and outside of CPD. So I think both overall have very good safety track records. But if the patient doesn't have type 2 inflammation, there are some other options. You've got roflumilast, which is um, a PD-4 inhibitor. You also have azithromycin, which everybody knows is an antibiotic, but also has some anti-inflammatory properties. Both of those can be considered. There, in individual patients, maybe some tolerability issues that you want to think about and might help further guide choice. So those are really, I think, your options for exacerbations. I think the exciting thing is that if you and I have a follow-up conversation next year, I think we're going to have even more options to talk about. And if we were to have a conversation the year after that, there's probably going to be even more options. So I think honestly, for years I had conversations with patients and they came in and they said to me, what have you got? Do you have something new? And I feel like 10 years went by and I had nothing. And then suddenly, wow, we actually have something. So I think the message for my primary care colleagues is we have some things. So again, we're really happy to see these patients.
Great. Yeah. We're happy to send them to you. And especially as we start to get more and more things that can be done, I think that always sort of implores us to send them. So
So I'm curious, I've tried to build out some things in our medical record. It's been challenging because, getting attention of IT and getting on the list for getting any kind of build takes forever. But um, short of that, what are some practical ways that you think primary care clinicians or physicians in general can track steroid exposure?
yeah, I think on the primary care side, depending on where you're practicing, it can actually be quite challenging. Um, if you're in a mostly sort of captive system, where your patients go to the urgent cares and emergency departments and, offices within your own system, EHR network, it can be a bit easier because you do tend to get notifications as to when someone's going. I know at our hospital, if they go to our hospital, they go to one of our urgent cares, I automatically get a notification that someone's been there. The problem is we have multiple, private urgent cares. We have competing health system emergency departments. One of the competing health system emergency departments is pretty good about sending stuff over. The largest hospital in our area, not so good at sending things over. Whether that's discharge summaries or notifications that anyone was even there. So we're often relying on the patients to come in, and whether it's primary care or pulmonology, often for exacerbation, some of the first line are some of our, advanced practice providers, our nurse practitioners, our physician assistants, that might be seeing those folks as well. So sometimes we don't even know that someone has gotten a script for something. So being very clear to your patients. I think also helping with your, local urgent care and ED physicians, please tell your patients that they need to follow up with their PCP to schedule, even if they're feeling well. Emphasize to them that, hey, exacerbation is a big deal and you may need something else. So I think asking our patients and asking our, kind of first line folks to really make sure that they are getting things and our patients back to us so we can keep track of them. So yeah, that to me is, I think, important. And also, again, we already talked about, not necessarily giving them, self management is great, but self management, especially when they're using something and then don't let us know that they've used something, can be really problematic because then we don't know that they're exacerbating. So
Right. That's really, really great advice. Thank you. So, as we conclude our discussion, I want our audience to kind of think about everything we said and see if you can think of one practical step, one practical takeaway from our discussion today to try to reduce repeated steroid exposure in your patients with COPD. Nathan, I want to thank you so much for joining me. This was a really great discussion. I enjoyed it. I hope our audience enjoyed it. And I want to thank our audience for participating in this activity. And please continue on to answer the questions that follow and complete the evaluation.